Well, thank you both, and thank you MedEd Combine for having us here. And I appreciate you guys still sticking with us, hopefully, and watching on your end. I'm coming here from Roanoke, Virginia, and I'll start off with a little joke, if you don't mind. So basically, I would say, why don't
I'm excited.
you don't mind?
I'm excited for it.
So,
Why
don't you trust an atom?
Why don't you trust an atom? I don't know.
Because they make up everything. All right. So sorry.
That's kind of a joke.
I appreciate that.
That's good.
Thank you.
That's like only a scientist would appreciate.
Yes, exactly. Well, my name is Chheany, not Adam, so hopefully you'll be able to trust me as I give you this lecture today on spinal cord stimulation as well as the Nevro. So based upon spinal cord stimulation therapy, we're going to talk about this from a standpoint of how long it's been with us. So this is part of our armamentarium from a pain physician standpoint. So every pain physician is able to do this. So I'm not going to talk to you about anything super new and super exciting from a standpoint of technique or a new device, but I am going to talk to you about a new indication. So stimulation therapy in general is performed all the time. So over 34,000 patients undergo this procedure worldwide every year. So as you saw with Dr. Patel, basically the leads for spinal cord stimulation, they're 8 contact leads typically. And normally you'll put 2 leads, and these leads are connected to an IPG or a generator that you implant for the permanent implant once somebody passes their trial. That generator delivers an electrical current into the spinal cord and stimulates the spinal cord and then essentially blocks the pain from going to your brain. And then based upon the different types of therapy out there, you'll have traditional or low frequency stimulation, which I've been practicing for over 10 years. I can't tell you how much longer after that because I don't want to date myself. But basically, traditional stimulation is low frequency, anywhere from 2 hertz to 1200 hertz. And we used to use this all the time, right? So we use it for a lot of indications, typically for any type of radicular or neuropathic pain. And we try to use it for axial low back pain, which sometimes we have difficulty covering for that. And today I'll talk to you a little bit more about painful diabetic neuropathy. The difference is that we're going to talk to you about a Nevro, which is a high-frequency stimulation system. So this is the only one that's approved to go above 1200 hertz, and the normal hertz or frequency is 10,000 hertz, which is crazy when you think about that type of energy being delivered to the spinal cord and be able to deliver that why do we do it? Well, we want to get rid of those paresthesias, right? So you don't want to, some people love the paresthesias. So how I describe it to my patients, I'll tell them that, they'll have some numbness, tingling, or they'll have more tingling or like a million different fingers that are massaging that extremity or your back to try to alleviate and get rid of pain control. So the high frequency stimulation has no paresthesia whatsoever. So as you'll see the differences between the two systems, low frequency versus high frequency, it's actually can be pretty significant for that type of patient that you're trying to treat. So why high frequency? Where did it all come out? So we're talking about the mechanism of action. So for low frequency, or what people will call tonic stimulation, low frequency stimulation will stimulate the dorsal column. So that's how low frequency stimulation works, and that's how the pain control comes from. For the spinal cord stimulation, where you're using high frequency, it stimulates the dorsal horn. It's a direct neural inhibition at that level. So for this system, we have access to use for Nevro. We can have access from anywhere from 2 hertz to 10,000 hertz in order to treat our patients for the pain that they're having. So once again, I said high frequency is paresthesia free.
And this is great because it gives your patient options. I tell Kyle all the time, my job is just to put the leads in. And that's one thing I love about Nevro is we put the leads in, very similar place almost every time, and then it's his job to get them better. But there's so many options. I mean, it really blows me away how many, even during that trial period in 5 days, sometimes we do 4 or 5 options for the patient. They could say, hey, I'm 50% better. Like, let's try another one just to see. And that's really good for the patient because I think one thing we see with spinal cord stimulation in general is even if they get a good 2 years of relief, it kind of can fall off. Here we can kind of switch back and forth if we need to. What I've seen, it has the most versatility.
Completely agree. And so we talked about for the indication for driving. So it's the only stimulator company that has an indication for driving. So I would tell you whenever we do tonic stim, I'd have some patients, I'd put a tonic normal stimulator in, so to speak, or a traditional stim in. And I'd have to tell them, be careful if you're leaning back on it. If you lean back on it, that stimulation is going to light you up. So if you're driving, obviously you don't want something to jerk you when you're trying to drive with the stimulator on. So the HF, or high frequency stimulation, is approved for driving. in terms of paresthesia mapping, so the tonic stim, when you put it in, you have to make sure that it covers. So you turn it on, it develops, causes paresthesias that covers the area or the limb or the area that they have the pain, and you're hoping to map or try to determine exactly where the pain is and make sure it covers that area. Difference for high frequency, it's very predictable. It goes in the same spot, same place, very similar to Dr. Patel when she talked about DRG. It's a very particular location, nothing really changed. And I can tell you from a standpoint of doing my own implants as well, is that doing an implant with tonic stim, when I would sit there and have to wake a patient up and try to figure out if they're feeling
And they're
stim.
half drunk, and they're like trying to tell you, oh, I feel it in my hip. You know, like, what do you mean you feel it in your hip? And it's just the way they're lying on the table. I think it's so much better to take the patient out of the equation if we can.
Right, so I can put them under general anesthesia. I don't have to necessarily worry about waking them up to just try to determine where the stimulation coverage is. And from in terms of procedure time standpoint, it's cut my times in half.
Oh, yeah.
I mean, it's so much easier, so much better for the patient, so much easier for us.
Less anesthesia.
And less anesthesia and less time, right? So sometimes I'd be, unfortunately, an hour and a half, 2 hours just trying to put this in because, their SCDs would be going off and they're like, I feel it in my legs. No, it's your SCD. Somebody turn that off.
Exactly.
So, I mean, it happens to everyone.
So the question that comes up a lot of times is if you're going to have a patient under anesthesia during the case, you're not going to wake them. How will you know you covered the right area and things? But also, do you neuromonitor any of your patients when you do this procedure?
I don't personally, but I know some people have done that, which is a good option as well. Do you with yours?
Not all the time, but I know that there's a lot of people that I've seen that do it on every patient. And obviously the benefit there is that if a patient can't respond because they're out of it,
Sure.
that you're out of bounds. And so just something to think about. It may be different in each area of the country where you live, but it might be something you might want to add to your training.
Yeah, no, absolutely. Having
I
those
think if you're
options.
definitely under general for some reason too.
Yep.
If they're under MAC, they'll still let you know a little bit. As long we don't keep them that deep usually.
Yeah. And you also want, we'll see when we put one of our leads in that you also want to make sure you get a lateral lead. You want to keep everything, as close to midline as you can, but the lateral will tell you that you want to be posterior in epidural space, so that will also help us make sure that we're good for the patient, because obviously we're here to do the best thing for our patients.
Perfect.
So the really exciting part, so the reason why I'm here, and it's going to be a little more didactic than you've seen past, so I'm not going to have some large equipment, I'm not going to break stuff or hammer things. I'm really just here to
hammer.
Where's the drill?
I mean, I
Get
could
the drill.
try, but that would be fun actually. But basically, so Nevro has an FDA indication which came in July of 2021 for painful diabetic neuropathy. So what's exciting about this? Why do we care? It's exciting because there's no other really good treatment options for people with painful diabetics, right? So what we would do, it's a lot of medication management. So I did try using regular tonic stim before for neuropathic pain and neuropathy, but sometimes it was hard to cover. It's a little bit unpredictable at times, so that's what makes it difficult for me is that, and there wasn't really good evidence. So we were here just to present a lot of just evidence and data based upon the study. So next slide, perfect timing. So it's not like I practiced before. I just came up just random. So this is the largest randomized controlled clinical trial studying spinal cord stimulation therapy for painful diabetic neuropathy through the high frequency stimulation system. So over 200 patients were in this study. They're randomized 1-to-1 for conventional medical management, or I'll say CMM, you'll hear that, and versus CMM plus spinal cord stimulation therapy with high frequency. These patients had pain for over 7 years. So these aren't patients that just been diagnosed. These patients have pain for a long period of time. Their pain scores were at least a 5 or higher, and they failed 2 different types of medications that we normally use to treat for our diabetic patients. So at least one had to be a gabapentinoid, so Lyrica or gabapentin. And then typically the other one can be anything like a topical cream, it could be a tricyclic, it could be Cymbalta. So some of those medicines have norepinephrine in them that helps block that pain signal.
And I think the great thing about this study is if you had this patient right in front of you that was entered in the study, what would you do? They failed 2 medications, they failed conservative therapy. What would you do? You would almost just tell them, live with it.
Yeah,
Opiates.
stuff, right?
Opiates,
Yeah, exactly.
There you go.
Pain meds.
Yeah,
And all that's
we're
doing
still-
is making them, So this is what's exciting about our field and companies like Nevro is they're pushing the envelope and giving us more options. A lot of people, it's not, companies aren't just, we're helping these patients that we couldn't help before at all. It's not like we're just doing another layer on top of the cake. This is a whole new field of patients that had no other option.
Correct.
So that's impressive to me. And the nice thing I like about this study too is you guys could have just said, let's just do it for painful diabetic neuropathy. You're doing it for the patients that didn't respond to everything.
Right.
So that's even a harder study because these patients already failed everything else.
Right.
So that's impressive.
Right. No, thank you. And we know treating patients with those medications, I mean, they can't tolerate it. You maximize your doses. There's a bunch of side effects. And it's really difficult to try to find an option. So I love the idea of just expanding the field. We're not, like you said, layering the cake. We're actually presenting a brand new indication for patients that were really poorly treated before, and us as pain physicians.
And no other option.
It's difficult, right? They have nothing else they can do. 18 centers, like I said, 1-to-1. These patients had a hemoglobin A1C of 10 or less. So we can talk about that now.
Yeah, we can talk about that now.
Yeah,
That's
sure.
one question I always get, and I think I asked Kyle the first day that I heard this study came. I remember this study came out. I saw it on LinkedIn. I was like, did I miss something? And that was the day it came out. And I didn't know it was coming. It was pretty cool. I'm like, we can do painful diabetic neuropathy now? I'm like, wow, what a game changer. But then, of course, the first thing on my mind was we're going to be putting implants in patients with poorly controlled diabetes. So I think, do we have that? I don't know if we have the infection risk, but you can speak to it.
Yeah. So basically, Nevro looked at this and said, okay, obviously it's a concern, right? So we're dealing with patients that poorly control glucose levels. They actually push the envelope to go at A1C up to 10. And I'll tell you, in our hospital system, we don't do anything higher than 8. We can't. We're not allowed to do anything higher than 8, so we stop and cap at that level. They pushed it up to 10 just to see how obviously these patients are struggling. They need to find an option. But basically, they looked at the infection rate, which based upon all the studies in terms of implants, the infection rate and leading to explant of the actual device ranges anywhere from 2 to 9%. So in this study, their explant rate for patients who had the system was 2.2%.
And I think this is a good time to
crazy,
talk about overall with SCS. What is your antibiotic regimen?
So me personally, I'll usually use a gram of, so they'll have a gram based upon their weight, 2 grams or 3 grams based upon their weight. If they're above 100 kilos, I'll go 3 grams of Ancef for their trial. And then I normally, personally, I don't put people on antibiotics after that. I just do a single dose. And for the same thing for their implant. And if they're allergic, I'll use Clinda 600, 900 based upon weight.
Very similar.
That's pretty standard.
Yeah, good. This is good for everyone out there to know because this is the stuff you have to start thinking about before you do every single procedure. Think about the antibiotics. Think about how you can hurt the patient. If they get an infection, think about how you can fix the patient.
Of that 2.2%, was that, because I haven't read the whole study, was that explant because of infection in the pocket or otherwise?
In a pocket IPG.
Pocket.
Yeah. Which
That's
for
where you
us,
gotta watch.
That's where it starts, and then
always
it'll
starts
come
right.
there. Yeah.
That's why you got to have really good skin control and really good.
I clean out my
bathing
pockets too.
Yeah. Clean out your pockets.
With
I thought that's what I was. Oh, just
with
with irrigation.
Irrigate the
Yeah.
pocket with. Yeah.
Which I don't use bacitracin, so I don't. I was like, why is he cleaning out his pockets?
Crazy.
Well, I thought you were cleaning out.
Yeah,
like pulling your pockets out. I'm like, all right, well, that's nice. I'll step back a little
Let's
bit.
get
I
to
thought we were talking about
to the ground.
I'm sorry. So
Golly.
before I forget, the previous slide, if you can put up the previous slide up.
Sorry.
So not only are they did studies, this is obviously, we're here for pain management, right? So they presented this data and published this data in JAMA Neurology, right?
Yep.
So why would a pain company publish in neurology as well as diabetes care? So they actually went and did it to the next level where they published in a different specialty than we're currently practicing. And they presented 18-month data. So, I mean, that's smart, right? That's smart if you have the data to support it.
You're a
why not?
neurologist. What else are you doing besides med management?
Exactly.
So that's an easy.
And I think
referral
that's
to
one other
pain.
spot where I can come up, and I just asked you guys, I don't want to name other companies. Another company just got indication for painful diabetic neuropathy. If you're okay to talk about it, I mean, the difference or what you think.
Yeah, I mean, that's a good thing to talk about. Another company, Medtronic, did a study back in 2015 on painful diabetic neuropathy. And they've had this data for a while. They just, after we got our indication approved by the FDA, they got FDA approval for their study as well, which overall I think is a good thing for the space. It's a good thing for neuromodulation. This is an met need for these patients out here with painful diabetic neuropathy. This is really the first good non-opioid option that we can offer these patients. So it's just good for the space to have more clinical evidence out there. I hope more companies continue to put more money into research. So from a macro level, I think it's good. But when you start to actually look at the clinical evidence of what Dr. Ung is about to present versus what the other study was done in 2015 with a small sample size of 17 patients, I mean, you'll see the difference in the quality of evidence.
For for sure.
I agree 100%. So we'll talk a little bit about those differences a little bit later as well, and obviously we want people to make sure they understand that they have options, right? So this whole idea of why we're here is providing options and for treating an underserved population. So from a standpoint of stimulator studies, so most studies are maybe 3 to 6 months. So anytime I see a study go past 6 months, because in my patients, sometimes I'd have stimulator patients that would have, you put it in 6 months, they're like, oh, I'm not getting relief anymore, I don't know what's going on.
It's disheartening. Yeah.
And what do you say? Oh, your disease probably got worse. It wasn't me, it was you, right?
Yeah.
It's not me, it's you. So your disease progression is the reason why you don't get coverage. So, I always think, well, okay, maybe we can adjust it, we change the stimulation, hopefully we get coverage for. So anytime I see data that goes beyond 6 months, it blows my mind. So this is 18-month data, and it shows you in terms of the durability of the data they have. So these patients, you'll see on the bottom curve is the blue curve, which is the Nevro curve, and you'll see the gray curve is above. That's the CMM patients, the conventional medical management patient. These patients had on average a pain score of 7, right? So they're pretty uncomfortable, pretty miserable. And you'll see that the curve dropped to about a 2, so about 70-ish% decrease in their pain control with the Nevro arm, with the Nevro plus the CMM management. Interestingly enough, they followed those people out to 6 months, the people that didn't get the stimulator implant. They followed them out to 6 months and said, we'll give you an option. Do you want to try this trial with the system and see if that will help you? Or do you want to just stick with 7? So, and you'll see as they trend, and this is what happens a lot, right? So it's not like the diabetes or neuropathy is going to get better. It's not like their pain just automatically improves. They were somewhat trending up in terms of their having more pain. So they say, all right, let's jump and see if we can cross over. So they did a crossover study at 6 months, and at 6 months, those patients followed the same curve after 6 months in terms of pain relief, which is unbelievable. So for me, when I look at this, and this is probably one of the most impactful slides, is that why wait, right? Why wait to deliver somebody pain relief that is absolutely miserable? And I can tell you from like a personal patient of mine that I have. So I have a patient, I live in Southwest Virginia. It's not Florida, it's not the cool places. Or Baltimore, sorry, I don't live in Baltimore. So, so I live in Roanoke, Virginia, which unfortunately some of our patients are a little larger than other patients. A little fluffier maybe, some people will think. So anyways, obviously, they're still trying to work. I have a lot of blue-collar workers. I have a patient who's 44 years old. He actually has his own pizza company. So this guy loves making pizza. And basically, for having part of that pizza company, he has to stand up all day to be able to do what he loves to do. Unfortunately, he can't do that. He wasn't able to do that because he would spend his time delivering pizzas because he had to get off his feet. He couldn't stand for too long because his feet were just burning and tingling all the time. And he would come in wearing slippers. And like this guy would not even be able to wear shoes. So when this data came out and we were approached and saw it, like you said, through LinkedIn and different sources, we ended up saying, hey, this is an option for you. Let's try it. His A1C was about 7.5, so he was still able, someone I could still implant. And then basically we trialed him. This guy just completely 180. So he was about 80% relief for the trial. First time he could wear shoes, like literally sneakers, for him to wear sneakers. And he could spend all day making a pizza. I mean, that's all what he wanted to do. I mean, he makes great pizza. So you guys ever come up and visit Roanoke, you have to come visit.
So what we're talking about is not pain relief only. We're talking about functional improvement, lifestyle improvement, getting him back to his vocation. Yep. That's huge.
Right. And we'll see it was more than that in terms of just, so we're pain physicians, right? So what do? We treat pain. But you'll see in some data that I'll show in a little bit that beyond the level of pain, they had a lot of sensory improvement, motor improvement, and we'll show you.
Let's finish up this data so we can at least show the placement of where we want to go.
So quickly through these. This is next one. Cool. So 85% responders, so 85% people had 50% pain relief or more. They had an average pain score reduction of 70%. And then you have the 70% of patients who are remitters, which basically means they're super responders. So they had at least a pain score of 3 or less for 6 consecutive months. Like how many people in your clinic can you say has pain scores less than 3? On the right-hand side is what Nevro is kind of known for in terms of their data is tornado chart. So each line, horizontal line, represents one patient. So you have some patients that had 100% pain relief, and then, like I said, 85% of those were responders. Okay, next slide. So this talks about sleep. So my guy was able to sleep throughout the whole night, was extremely comfortable. And with tonic stim, the issue with tonic stim sometimes is why would you want your legs to buzz and tingle when you're trying to sleep, right? So this is the part in terms of their sleep disturbance improved by at least 60%. So this is what I talked about: sensory improvement, motor improvement, reflex improvement. So on the left-hand side is our baseline. So the darker the color, so to speak, the red showed the percentage of patients who had that type of symptom. So red's 80% of people had numbness, 80% of people said they had tingling, so on and so forth. At 12 months, they measured those types of sensory, reflex, motor deficits, and you'll see that the lighter the color, that's how many less people had those symptoms or reported those symptoms. So for me, this is what, I mean, if you think of it, expand this, and hopefully some point, this is just the beginning. We're looking at obviously more indications and see what this is all about. But for them to have neurologic improvement, so most patients necessarily don't have a whole lot of pain, so to speak, sometimes, but sometimes they can't feel their feet. Sometimes, imagine giving some sensation back to a diabetic who has chronic foot ulcers, right? Maybe you can prevent some of the things down the road using high-frequency stimulation.
When I go to talk to referring physicians that really see these diabetic patients, podiatrists, primary care, neurologists, when I show them the study, we talk about the pain, and that's all great. When I get to the information about the neurological improvement, that's what they really get excited about and want to actually start talking to their patients about this therapy to refer them out.
Now that's huge to think that maybe you can even get something back.
Yeah.
So let's just show the placement. I think we have a lead in already, right?
Yes.
Yep.
So take a picture. Come up. Can you just pull that down, actually, or pull the body down? There you go.
That's much easier, yeah.
There we go.
So, I don't know if you guys saw that, but I just put that lead up. That's how.
That was
quick it
amazing.
goes.
I don't know. I mean, just put it there. It just happened and just done. See,
Dude,
so I
you're
already
good.
put it at the top of T10 or at the top of T8. So you actually, the leads are a little different from where we normally put our stimulator leads. So one lead goes in the top of T8, and the bottom lead, so the 16th electrode, will go at the top of T12. So based upon that, normally take a shot, picture.
You got a foot pedal there too.
Oh,
Yeah, you have
perfect.
the foot pedal
Oh,
there.
yeah. Awesome.
On your left.
Even better.
Yep.
I'm too lazy. Sorry, guys.
No, it's all right.
Come down towards the feet a little bit.
Move this up if we have to.
Oh, yeah.
Okay, go ahead.
Perfect. So we have that. So you need a little tilt towards the feet or towards the bottom here. Pretty similar. And then could you rotate towards you a little bit? Or a blight towards you? Oh, no, this way.
Toward you.
Towards you, yeah. The other way.
Oblique toward you.
There you go. That's pretty good. Yeah. So let's see where we are. Picture. So what I do is go on, and I see so many of the DRG stuff. Let me take
Yeah, I thought I got all that. I'm sorry.
You can pull it
Pull that one out. We don't need that. Yeah.
picture. I feel bad. That was pretty good placement. I hate taking it away. So picture again. So trying to see sometimes it's hard. Do you have, oh yeah, great, great. So normally I would localize the skin here. Picture again. And usually, like I said, you want to go in the pedicle below. It's actually almost a little higher.
Are you trying to go on the left side or the right side?
I want to, oh, that's a good point, because this guy has a little scoliosis.
There's a curvature,
so,
yeah.
Yeah, it makes it a little more. Picture. So there we go. Picture. So basically, how I do it, I always say there's different ways to skin a cat, so to speak. So basically, I want to go down to mid-pedicle below, and if I can land on os, that would be ideal. So just generally, so I'm on os there, and your target is the top of that epidural window. So I'm a little lateral, but I'm just going to show you kind of access. So I'm right before the window.
I think this is good for, anyone out there that's learning spinal cord stimulation. Use your imaging.
Picture.
Nice, that's perfect.
So I just kind of slowly advance. So you'll see that my angles are very low. So you want to keep these posterior. So if you can go posterior, picture. You want to go this posterior. You got to keep your angles low. Different from a normal standard epidural, and you'll see the loss there. So it typically can be pretty dramatic. Picture. So we have normally these are a little closer to midline, but so I always, when I do my trials, I try to think about how am I going to do this implant. So I like to keep my entry points, if I can, close to each other. Great. So let me move up just towards the head a little bit. I personally do mine under live. Picture again. Just go live. And I'll just try to bring that back over. So ideally, so if I get too far out, picture again. I'll try to turn my bevel to try to keep it over towards the outside of the other lead. Picture. Picture again. So hopefully that will start. And live again. Yeah, that didn't make it better.
So
Yeah. So basically, the goal of the electrode
is to put it.
is to put it just right the same way. Picture again.
So we're looking to have the top lead. Yeah, there you go. Put on the skin right next to each other. And Kyle can explain. We have about 1 minute left. Explain how that works for you guys.
Yeah, so our placement, it's very easy. There's just a slight difference between what you would do for a typical back and leg patient versus what you would do for a patient with PDN. For back and leg, we like to stagger our leads. We like to have one lead top of T8, the other one starting at the middle of T9. For PDN, we want that first lead to still be at T8, that second lead just to be a little bit lower. We're not so worried about where the top of the contact is, but that bottom contact, we want to span the T11, T12 disc space. So as long as we get that last electrode contact 16 to be at the top of T12, we're in a good place. We're spanning a lot of different vertebral bodies, and we're going to get everything we need there.
You want it
guys.
pretty midline?
Pretty
Is that the
midline,
goal, midline stack?
It is, but with us, with high frequency, if the patient really has unilateral pain and it's left-sided and you get the leads a little bit more to the right, that's okay. Our placement's okay either way.
Yeah, that's the nice thing about it for me.
Well done.
You get them in and let the
Yeah.
reps do the work.
Yeah.
Thank you very much.
you.
That was
No
great.
pressure,
I
Kyle.
love going over the
Good to
data.
see
I
you.
love showing everything. Thank you very
Good luck.
much.